This episode of The Cutting Edge is brought to you by Cook MyoSite.
Dr. Bordeianou, welcome so much to The Cutting Edge. Obviously, you're the head of colorectal surgery at Harvard, is that correct?
No.
Oh, MGH.
It's confusing.
Okay.
There's multiple Harvard hospitals, and
Yes.
so I lead the Mass General colorectal group.
And you are a specialist in the field of pelvic floor disorders, is that correct?
That's my passion for sure.
And I'm glad that people like you exist that have a passion for this, because it is such a complicated anatomy, and from a physiology standpoint as well, there's so much going on in that area. But you're really focused on the issues with rectal diseases and with, well, I'll let you go ahead and describe it.
Well, so it's actually very difficult to draw a line, and that's part of the problem with pelvic floor, is that traditionally it's been siloed. So colorectal surgeons draw the magic line and it's the rectum, the urogynecologists deal with, vagina and the uterus. But actually, we as specialists have to fix both at the same time. So yes, the majority of the problems I fix are constipation, fecal incontinence, rectal prolapse, but a lot of times that requires fixing vaginal prolapse at the same time.
And you were telling me, fecal incontinence, this is a much bigger problem than I ever realized.
Oh, it's an epidemic. And it's an epidemic that starts in the young. So in a woman in her 30s, the rate will be about 10%. And by the time you are 80-year-old, about 50% of patients will report some episodes of incontinence. But obviously not something that people talk about at the dinner table.
Yeah.
So every patient walks through the door thinking that they're completely alone, that they're unique, and nobody knows what to do about them.
And what is causing this epidemic?
I think it's multifactorial, but a big disservice we've done to our patients is, around the lack of education about what to do when you're pregnant. And so a lot of women get injured in childbirth. That's probably the biggest cause of fecal incontinence. And it can be either direct sphincter injury or just stretching of the pelvic floor. And then diet, different disorders that then pile up with age, inflammatory bowel disease, every other cause of diarrhea, neurogenic dysfunction. And that's, all adds up and piles up over time.
And so this isn't just women that have had C-sections, this is women that are having natural births as well? It doesn't.
Or natural birth is one of the main causes of fecal incontinence, scarily.
Really?
Yes. Mm-hmm.
And is there any great solution to this problem?
We don't have a cure for fecal incontinence, and the definition of success in the fecal incontinence literature is 50% reduction in the frequency of the episodes, right? So the bar is very low. And even with this low bar, currently we are stacking and sandwiching treatment. There is no one intervention that we can point to say, this will cure your condition. There are lucky people that might be cured with a particular intervention, but the majority need a multi-pronged treatment.
So if you're a young woman and you start to notice this, what would be the first lifestyle things you would want to do?
We always start with dietary modifications, increasing fiber, but it doesn't work on everyone. It works on a lot of people, but not on everyone.
And my understanding though is currently you're looking at a very advanced treatment now. You work on something called the Dignify study. Can you explain to other surgeons and to the population, what is this study? What are you working on?
For you to understand why this is so exciting, I'm going to backtrack you a little bit. So, what happened to us in the last 10 years with fecal incontinence is that some of the treatments that we had available for the condition were pulled. They were taken away, even though they were partially effective, like injectables, like mesh, for example, treatments. because of the fear that the industry had that they are associated with infections and the whole concern about putting foreign bodies around the anus, etc. So we lost the artificial bowel sphincter. We've never had FDA look at devices that are being used in Europe that use injectable products, etc. So in this context, now comes this idea that forget about all of these foreign bodies that you're putting around the anus to strengthen the anal sphincter. What if you actually took the patient's own regenerative, ability to just build a new sphincter from scratch, essentially, using your own cells?
So this sounds like that advanced technology we've been hearing about for the last 20 years, but now we're at a point where we're actually...
It's here.
It's here.
It's yesterday here. We already have phase 1 and phase 2 data that this is very, very promising. So now we're going for the bang and we're doing a big multinational randomized controlled trial to actually show it against placebo. So it's very exciting.
Are you able to kind of step by step, what does this look like?
Okay, so essentially muscle cells, right? When you go to the gym, you exercise, it hurts like hell, and then you grow new muscle, right? So how does that happen? There's these progenitor cells that live inside all of us. They're usually surrounding the myofibers. And these cells go into action whenever there is a little bit of a micro injury to the muscle, and they make the muscle bulkier and they regenerate it. And so the idea of the technology is to find that progenitor cell, grow it in the lab, multiply it, and take a ton of these cells and inject them in the area of injury and see what that happens. And so because a lot of women with fecal incontinence have the condition because they had an injury to the anal sphincter during childbirth, they're a perfect candidate for receiving this targeted progenitor cell injection circumferentially around the anus and telling the muscle, grow, baby, grow.
Yes, and these are not stem cells, correct?
These are not, no, these are different in the sense that they don't differentiate left and right to whatever happens to be. These are muscle cells who know how, progenitor muscle cells, who then make myofibers and myotubules. So very targeted, patient's own muscles being put to work.
And does this require a big operation to undergo?
It is not a big operation. It's an involved procedure. It takes a little bit of getting used to it, but ultimately I think it will be translatable and any colorectal surgeon can be taught how to do it. We do it under local anesthesia in the office. It takes a little coaching, but it's pretty well tolerated, and it's actually 2 procedures. First, harvesting the muscle, which we do. It takes about 10 minutes of local anesthesia. It's a little uncomfortable, but bearable. And then once 2-3 months go by and these cells grow in the lab, we get them, we thaw them out, and then we inject them in 12 different points around the anal sphincter. And they implant along the needle track and they spread out, but not a lot. It's not tumorogenic, so because obviously that could be a concern.
Yeah.
And not only do they spread a little bit and they grow, they start creating a new nerve circuitry as well.
Really?
There's a little bit of innervation that happens. And for the first time, there's been all of these treatments for fecal incontinence, like sacral nerve modulation being an example. Nobody has ever been able to show an improvement in muscle strength with these treatments. And phase 1 and phase 2 data on progenitor cells shows an improvement in manometric pressures in the responders. So clearly something happens, not only making the muscle bulkier, but actually reteaching the muscle how to work. So that's the exciting part.
And even pulling the muscle out, all of this is in the office, so none of this is being done in the operating room?
Nothing in the operating.
Wow, no, that's really impressive. And when you compare it to the nerve stimulators, where do you see the benefit of this versus the nerve stimulators?
I don't think it's going to be one versus another. As I sort of alluded to at the beginning, we right now are sort of doing sandwiching approaches to treatment. And honestly, some patients don't want a foreign body. And so they're anti-stimulator, and they could be potentially offered going straight to, regenerative medicine. And honestly, probably eventually, if we actually show that this is beneficial against placebo, it might become the first line of treatment as opposed to the second line of treatment, which, just because the price of admission is so low.
But the other thing is interesting, since you can't, obviously these patients are living, you can't go in there and remove it and then run it through path and look at this from a micro standpoint. So how are you measuring outcomes on this?
A million ways. So traditionally in fecal incontinence research, we do a 2-week diary where women record their fecal incontinence episodes and how many times a day, how severe. And so the success is measured as a reduction, 50% reduction in these episodes. So, you know, if a woman started with 6 episodes in 2 weeks, then we want to see them go to 3, etc. So that will be the primary endpoint for the study. How many women have a 50% reduction in the episodes. But then also the more nuance, how many of them are cured? Because in the preliminary data, some women were cured of their fecal incontinence.
Oh, I'm sure that would be a huge blessing to anybody that would work
amazing,
for.
right?
And where are you in terms of the study itself?
So the setup, this is a huge study. So we have 26 sites across the United States, and each site had to be trained on the procedure, right? And then the screening for the patients, because we want a particular type of patient that had a fecal incontinence caused by having an injury. So we need to do ultrasounds, we need to do pre-evaluation manometries. So getting all of that organized took an effort. But now we're about 1/3 in as far as recruitment. We have 65 patients that are already randomized, and the 30 of them already got their injections. Obviously, some of them were placebo, but, and you know, we're up, recruiting very rapidly because I think there's a lot of desperate women out there that are interested in the technology and also desperate about getting a cure.
I did find it amazing when we were talking in the pre-interview, you had brought those numbers about just how many women this affects. I mean, you already reiterated them today, and it was mind-blowing. I'd never hear about this.
Well, you know, why do you think so many women or men end up in nursing homes? You know, sometimes it's not about immobility. It's actually the main reason patients are admitted to nursing home is loss of bowel control.
Wow, that quote right there is going to be the first one I send on a show. I did not know that. So how come that in the medical community we're not talking about this?
Not only that, it's trivialized. It's considered the normal part of aging. In fact, when we many years ago setting up a Center for Pelvic Floor Disorders at Mass General, and I went around sort of advocating for the multidisciplinary approach, a primary care physician told me, so you're medicalizing aging. Why do we need this service? You know, so that attitude still persists in the medical world. We underappreciate the suffering of these patients and trivialize it.
And you have all these sites around the country. If somebody, so what would be the patient population? I mean, you kind of outlined a little bit, but if I was listening to this and I was a potential patient, what should flag me as a possible person that should be out looking for a site?
Well, we're looking for women that gave vaginal birth, who had a traumatic delivery. And they might not have been told that they had a sphincter injury, but they might have been told that they were sewn up. So we are seeking this broad population first, and then we put them through a rigid screening where they have an ultrasound, and we look to see whether or not they had evidence of injury. And we want them to have, if they have a sphincter defect, it to be no more than 120 degrees. Because we want some muscles to be present in the area where we're injecting the progenitor cells, because the idea is that they will not only grow new muscle, but also stimulate the existing muscle mass. And so that's sort of a main criteria. And then we're excluding a more complex form of constipation that's caused, of fecal incontinence that coexists with constipation, because that's a prolapse type fecal incontinence that is a completely different algorithm of treatment that involves fixing of the prolapse.
And when you use the term traumatic delivery, can you define that a little bit for me?
Well, so when a child comes out through the vagina, a lot of times the head cannot fit. And so a choreographed way of helping the baby come out would be an episiotomy. But a lot of times the obstetrician doesn't have a time for it. And the vagina just tears, and then the tear extends into the anal canal, and it ruptures the anal canal, and we have gradations. But you know, sometimes the woman is lucky and she just has an injury to the perineal body, but the external sphincter muscle is intact. But many times the injury keeps extending and it injures the external sphincter and sometimes the internal sphincter, and women are left with what's called a cloaca. And then usually that's recognized at the time of delivery and repaired, but the muscle is so difficult to suture closed that these repairs are not fully intact when you study them on ultrasound 10 years later, 15 years later. And what's frustrating, well, what happens is the woman doesn't realize that she had an injury to the sphincter, because after the initial repair, they're continent. The incontinence develops a little bit later in time, and that's when, if you do an ultrasound, you might find the evidence of that prior injury, or even a little bit of a separation of the muscle because the repair that was done at the delivery wasn't, secure enough. It didn't last.
When you say a little bit later, are we talking days and weeks, or are we talking months or years?
Most women will have the fecal incontinence manifest 10 to 15 years later after delivery. Only very unlucky few have immediate fecal incontinence after childbirth. And that's because they can compensate. They are strong, young women usually. They have a lot of muscle mass and they can compensate.
Now, even if they had an episiotomy, though, they could still develop this, correct? It's just less likely?
Yes, and episiotomy is actually a risk factor for developing it, because the episiotomy just choreographs the rip, but the rip is still a rip.
Yeah.
Yeah.
And what do you tell your fellows when you're trying to get them up to speed, like what this is? Like, how do you explain to them to talk to their patients, or what would be the symptomatology you tell them to kind of to study when they're talking to the patient? Or how do you ask those questions?
You have to, first of all, you have to ask, and a lot of people will use euphemisms like, oh, I have diarrhea, oh, I need to be close to the bathroom, and then you have to probe. And if you ask, you're empathetic, and you normalize it, then the truth will come out.
It's interesting the way you said it. I really thought, like, so if I had, let's say, my grandmother here, and I'm talking to her, and she's telling me, I'm having diarrhea, or I'm having regular times where I have to run, but I guess I wouldn't necessarily pick that up as fecal incontinence,
Right.
and
Right.
especially I'm not going to be asking somebody in their 40s. Like, it wouldn't even cross my mind if they don't say something, and
they will not say it because of the stigma associated with this condition. People will hide it.
I guess, are there other ways that they hide it that we should be picking up on in a standard conversation? Because I'm sure, like, how patients are, they throw a hint.
Right, I need the aisle seat right? I must be in an aisle seat. Or where is the bathroom? Right.
Anytime I've heard that, I always assumed it was a urinary issue. I've never really put fecal incontinence on that list. So,
well, this coexists. So a lot of these treatments are actually developed in parallel. And the treatment that we're discussing will probably be effective for women with urinary incontinence as well, which is exciting. And maybe even to pelvic floor disorders of other kind, because we can, re-innervate and regenerate the entire pelvic floor. So this has a lot of potential.
No, that's amazing. Yeah, you've really opened my eyes to this whole field. I didn't take it that much into consideration. And it's like I said, we never talk about it.
That's right.
So in the world of pelvic floor, something else I've noticed, we've had a couple conversations with other specialists in this area, and it seems like so many of these symptoms just overlap that the algorithm to discern this is quite difficult, because, as I said, when I hear it from a general surgery standpoint, it's not that I'm not listening for it. Well, in some cases I'm not listening for it, but I'm hearing other things. Like, I'm hearing it's possibly this or possibly that. Is there a place, a resource that surgeons that aren't in this field can go to kind of get a better understanding of what this algorithm looks like to be able to help them?
No, and that's the biggest problem right now, and we're trying to fix it. So one of my passions is education and development of these resources. So we actually created within ASCRS a pelvic floor consortium, the whole mission of which is to develop more collaborative, pathways of care, collaborate with other experts that deal with these women and men, by the way. Men also have fecal incontinence.
Yes.
And sort of make it easier and more accessible to patients. So that's happening, right?
So family practice docs, general surgeons, to get the awareness out there, is there a way we can assist that, and especially to help screen for the patients that you're looking for? I would ask
about the symptoms, and then usually at every hospital there is somebody out there that has interest in this. It's either going to be a motility specialist as a gastroenterologist, or maybe a urogynecologist, or of course a colorectal surgeon. But you have to look for them. Right now they're not very well labeled unless you are at an institution where they have a formal multidisciplinary pelvic floor center, right?
Yeah.
But this is going to be fixed.
And
the future is not going to be working in secret silos in some hallway. Pelvic floor has come a long way, and it's, yeah.
Well, thanks to all of your work, we're elevating it. and making it much more well known. And I think that is a huge part of this. But if I was a patient that heard this, like they're listening to a YouTube short or something, and they hear this, how did they reach out to your group and become
I
a
think
possible,
there are
candidate?
multiple centers of excellence throughout the United States. Usually they, label themselves as pelvic health centers or pelvic floor centers, and that is always a resource for education and getting, the experts in their region. But I don't want to minimize the expertise of the local colorectal surgeon or the local urogynecologist. They might not have the big label and shingle, but they're still experts. So reaching out to their local, expert might be the first move.
And if you could speak directly to the patient population right now that's dealing with this, what would you want to say to them?
Don't hide. Don't accept living with this condition. It's not part of normal aging. It does have treatments, and there are people out there that are looking forward to help them.
Oh, I love it. So my last question I always like to end with, and it's a little different subject, but you've been around for decades now. You're obviously one of the premier institutions in the world. You're an expert in your field. What is that thing that you consider that's wisdom, that you can't find in the textbook, but that you've learned from all of your experiences that you say, you know what, if I hadn't experienced this, I wouldn't be able to know it? Be it about patient care, about clinical duties, about how to operate. What would that thing be, that pearl of wisdom?
Pearl of wisdom, do what you love and dig in, because the more you burrow into a subtopic, the more exciting that subtopic is. Somebody told me when I started as a fellow that I would become the pelvic floor guru. I would laugh because I didn't know enough about pelvic floor. It wasn't something that was even on my mental map.
Yeah.
But then as you ask questions, you get excited about answering those questions. You become more and more in love with the field, and next thing you see, you're pushing the science forward, but you're also feeling validated and satisfied with your career. So yes, do what you love and don't be afraid to ask questions.
Oh, I think that is amazing advice, and I can't appreciate enough everything you're doing for this community that I said it's definitely been underrepresented in the world of medicine, because I don't think anybody really realizes just how big of a deal this is. So I hope for everybody's sake that this trial goes as well as we expect it to. And once again, thank you for being on the cutting edge.
Thank you so much for the opportunity.